pet her, she'll sit here and yell at me the whole time.
She looks pretty happy right now.
Welcome, everyone. We're just going to give everybody about 1 more minute to log in before we start. All right, we can go ahead and get started. And so before we actually start, let's be sure everyone is able to select their language channel. The options available for this session are English, Spanish, or original audio, if you would like to hear the audio without interpretation. For people connecting through a computer, you can choose your language channel by clicking on the interpretation icon to the bottom left that looks like a globe. For people connecting with a mobile device, you can choose your language channel by selecting the More option, then Interpretation, then selecting your language from the available options. We also want to extend much gratitude to our interpreters today. We also have live captioning available that can be accessed by clicking on the multimedia viewer box on the right of your screen. Okay. All right. And so I would like to now welcome you to our webinar, Survivors of Gender-Based Violence in the Overdose Epidemic and Overdose Awareness Day event. My name is Jami Wilson. I use she, her, ella pronouns, and I am a training and technical assistance specialist with the National Center on Domestic Violence, Trauma, and Mental Health. At this time, I'd like for us to take a minute of silence for those we have lost to overdose. Feel free to lift up and honor your loved ones by typing their names or initials in the chat box. And so we'll be taking a moment of silence until 2:06 p.m. Eastern, 1:06 Central. Thank you. Thank you, everyone. Now for some troubleshooting tips about this platform. If you get disconnected from today's session at any point, please re-enter the session using the original webinar link that was emailed to you. If the sound is unclear, it is likely due to an unstable internet connection. If this happens to you, feel free to call in for a better audio connection. If you are experiencing technical difficulties, you can directly chat with Carla Alegria, also with the center, for assistance. If you are unable to contact Carla, please reach out to the WebEx tech support. Carla will post that phone number in the chat box. We welcome you to use the chat feature to share thoughts, questions, and resources throughout the session. Your screen may look a little different depending on what kind of device you are using. Usually the chat box can be found at the bottom right of the screen. You may have to click on the chat icon that looks like a speech bubble to open it. Let's test that chat feature now. Please introduce yourself in the chat and let us know where you are and where you're joining us from today. Our center is headquartered in Chicago, the unceded homelands of the Council of the Three Fires, the Odawa, Ojibwe, and Potawatomi nations. We invite each person to learn about the land you are connected to. One resource to get started is the website native-land.ca. And personally, I'd like to take a moment to acknowledge the history of the people who have come before us and the land on which we currently reside. So feel free to enter your own land acknowledgement in the chat. I am located in what is now called Louisville, Kentucky. Kentucky is the homeland of more than 20 indigenous tribes, including the Cherokee, Chickasaw, Shawnee, and Osage peoples. Today, I want to honor the land, the presence, and the influence of indigenous people of the past and the over 30,000 Native Americans living in Kentucky today. I also want to acknowledge enslaved Africans and their descendants who suffered the horrors of transatlantic trafficking of their people, chattel slavery, Jim Crow, and other harms that continue today. We are indebted to their labor and their sacrifice, which has been a primary influence on our culture here in the U.S. We must acknowledge the impact of violence and racial discrimination that has reverberated throughout generations and remains evident today. By failing to acknowledge those who came before us and who built these lands before us, we perpetuate the legacy of violence, genocide, and forced labor. Right. And so now, before we start our panel, I would like to invite each of our speakers to introduce themselves and tell us a little bit more about their respective programs. And we'll begin with Bettina with Harm Reduction Sisters.
Hi, Bonjour. Good afternoon, everyone. My name is Bettina Johnson. I am with Harm Reduction Sisters out of Duluth, Minnesota. A little bit about myself. I'm a person in recovery. I am a person with lived experience both in domestic violence and as well as substance use disorder. And so I am very passionate about the work that I do. I believe that, you know, in my way of looking at things, I look at it that I was given this opportunity and the second chance to try to help others in any way that I can and meet them where they're at, no matter if they're in the midst of active use or, you know, domestic violence, whatever it might be, being able to help them and I'm a mom of 3 girls. I have a 16, a 15, and an almost 13-year-old at home, and just being able to make a better change in the society in which my kids are going to be growing up in. And I'm just very humbled and very happy that I was able to be part of this today. When I was first asked, when I got the email and I looked at it, I was so busy. I had just come on the job. And so I got the email and I was excited to be able to come in and share, you know, where we're at here and where I'm at and who I am, and to meet everyone and build more connections. So thank you so much for allowing me to be part of it.
Thank you, Bettina. And if we could pass it along to Danny, please.
Hi, everyone. My name is Danny Clausen. I use they, them pronouns. I'm a person of trans experience. I'm also a daily cannabis and alcohol user. And I am the director of the Virginia Harm Reduction Coalition. We provide comprehensive harm reduction services, including syringe services and Narcan distribution, as well as other safer use supplies to Roanoke area, as well as the West Piedmont area, which is in central South Virginia. And I am really excited to be here as well. And I actually had the privilege of sitting at the same table with Jami at a recent convening, and we have the privilege of running a domestic violence program as part of our harm reduction. We do crisis stabilization. I'm sure I'll have for people who are experiencing intimate partner violence that are also using drugs, because it's usually very difficult for them to navigate the shelter services that exist. So I'm sure I'll have an opportunity to talk more about that later in the hour.
Thank you, Danny. And I'll pass it along to Isabel.
Hi everyone, I'm Isabel Klumpus. I use she, her pronouns. I work at Spark. I'm a social worker there. We are a small harm reduction organization in Baltimore, serving South Baltimore. We started as a research study on how to better serve street-based sex workers in South Baltimore, and have evolved a lot since then. We're a syringe service provider, and we provide low barrier services to anyone except for cis men who come through our door or call us, or we meet on the street. I'm really grateful for this opportunity. It's been really cool to hear about you all, and I'm excited to have this conversation. So thanks for having me.
Thank you, Isabel. And Mike.
Hey everybody, I'm Mike Brown. I'm the founder of Never Use Alone, the US National Overdose Response Line. Also a person in recovery with the assistance of plant medications. There's really not a lot to tell about me. I just a guy that had an idea, and now here I am.
Thank you, Mike. And can you tell us a little bit more about Never Use Alone? What is it?
Sure, it's U.S. National Overdose Response Line. Basically, when somebody is going to use when they're by themselves, they can call our toll-free number, and one of our operators will stay on the phone with them. We'll get their address and their phone number. Once they've given us that information, our operators will stay on the phone with them and make sure they're okay. If at any time they stop responding, we alert EMS to that caller's location. It's August 25th was our 50-year anniversary. So 5 years in business now, 50,000 calls and 200 EMS calls.
Thank you. Thank you, Mike, for that wonderful work that you're doing. Thank you all for sharing the amazing work that you're doing. All right. And so I do have a few questions for our panelists, and we'll start with I want to direct this first question to Bettina and Isabel, especially. Um, people experiencing domestic or sexual violence are at a higher risk for overdose, making overdose prevention and harm reduction essential within our anti-violence movements. What innovative strategies are you using to prevent fatal overdoses and help save lives? Bettina, would you like to go first?
Thank you. And I apologize in my introduction. I guess you caught me off guard being the first one, and I didn't really talk about Harm Reduction Sisters. So Harm Reduction Sisters was started out of a vehicle in Duluth by my boss and the founder, Sue Purchase. She was part of the very first ever syringe program in the United States. And so her knowledge is amazing, and teaching me the ropes and what I do. So we are a syringe service program. I am the mobile coordinator of our program. So I oversee our outlet satellite offices, and then I oversee our mobile unit. And so the way that we do that is we go out and we do alley crawls. We get on foot. We go into the community, both here in Duluth and all of northern Minnesota. But well, we've done stuff down in like the Twin Cities area, but it's further up from that, all the way to the tip of the state. So we like to go out. We hand out Narcan. We like to, have that conversation with people if they're willing to build a rapport with us. We try to just, meet them where they're at. If they just need somebody that needs to be talked, just talk to them or to listen, or, maybe bum them a cigarette or something, just something simple. We build that rapport, and that rapport from the participants that we have established is really good. And so when other people in our demographic of participants that we serve are going out and talking about the services that we render to our people, then that makes it more comfortable for them to feel okay in speaking to us. And so we just try to go out. We're trying to saturate the state right now with Narcan. We do a lot of outreach. We go behind, the casino downtown here in Duluth. We do encampment outreach. So we will go into homeless encampments. We'll announce our presence. Hey, it's Harm Reduction Sisters. Just doing street outreach today. Wanted to see if anybody needed anything, whether it was supply. It's really the way that we approach it has made it very eye-opening for me, but the way that we approach it and communicate with those participants has really spread across our people. And so a lot of people do come to us, even in our main office, and we'll have people that come in and just sit down and ask questions and talk about things. We ask data tracking, so we find out, have you had to Narcan anyone? If in fact you have had to Narcan anyone, has it been a reverse, and how frequent has that happened? So we do a lot of that on foot, in person. We're right there, right where they are. So.
Thank you. Isabel, would you like to answer?
Yeah, sure. That's really great to hear about your program. It's actually, I mean, I'm sure very different, but also we do a lot of similar things. So it's really cool to see how that's happening in another place. We have a bunch of different strategies. We started in 2017, and the outreach that we started doing involved like going out on basically on strolls where people are working at night, because the focus was on working with sex workers. And that has changed a lot over time, especially due to COVID. I know we're going to get to that, but because of the way that our center worked as sort of like a safe space where people could come and see a case manager, come and see a nurse, without having to provide an ID or anything, and just have it be like this space that was, safe, and no men could come in, and you just could sit and watch Netflix or whatever it was you wanted to do. Because of COVID, that had to change completely. So our outreach program became sort of our main thing during COVID. And that includes we see, I think at this point, I don't know how many people it is, over 300 people that we go and deliver stuff to. So we go into encampments, we go and, the same sort of thing where we say, hey, we're Spark, we're here. We go to people's houses or where they're staying, or we drop supplies. If someone tells us, hey, like, I don't have a place to stay right now, we talk through where to leave things for them. So whether it's, syringes or safer smoking kits, safer snorting kits, condoms, Narcan, all those things, we'll go. And if someone says, hey, like, could you put it in this alley behind that rock? Like, we'll write that down and we'll make sure that they get their stuff every 2 weeks that we do it. We also, another thing that I think is important, especially because there are so many people experiencing domestic or sexual violence in this, in our participants, is we also do, since we don't serve men, we also, if someone does have a partner, we'll provide services to them as well, because we know that partners and people that live with you are going to use with you. And if we only give it to you, they'll probably take it away, especially a man. So we do provide partner services for everything. So we say, how many syringes do you need for you and all the people that you use with? Like, that's a very important part of it. We also, we give out Narcan. We have a giant Narcan mountain in our office, and we like to get it down as far as possible, get it out to everyone, and also provide Narcan training for people, anybody who wants it. And also we give out testing kits for xylazine and fentanyl, just to make sure that, you know what's in your stuff. Especially xylazine has been a really big thing that's come to Baltimore recently that we didn't know too much about. So we're learning about that and making sure people know whether it's in their supply. Yeah, that's some of it. Thanks.
Hey, Jamie.
Amy, I believe you are muted.
Thank you.
Sorry, and I don't, if I have just a really quick second, I wanted to add one thing that she brought up. It triggered a thought in my head. So one thing that I wanted to just touch on really, really quickly was we also have our drug checking. And we are going to be rolling that out here in hopefully a few weeks. We're just waiting for the final certification for our drug checking technician, and it's the FTIR machine. So we will be able to bring that along in the mobile unit to be able to bring that to participants so that they know what's in supply. So thank you.
Awesome. Thanks for sharing that. And all I was saying is I just heard some similarities, some common themes of you all meeting people where they're at and building rapport and relationships with people so that you're able to reach the most, pe as many people that need your services and support. So thank you. Um, the second question I'd like to direct to Mike and Danny, but I, I will also check in with you, Bettina and Isabel, to see if you wanted to add something in regards to this question as well, because it's pretty significant. It's focusing on COVID-19 and how we know the pandemic led to so many more lives being lost to overdose and suicide, as well as an increase in gender-based violence, all of which continue to grow. How do you continue to outreach? How did you continue outreach and support during the pandemic? And how have these strategies evolved since then? And we can start with you, Danny, if you'd like.
Sure, yeah. So our program began informally in 2017 and incorporated as a nonprofit at the end of 2018, although we were still in unsanctioned programs. Our activities were illegal at that time. And I wasn't with the organization at the time officially, but I was a friend of the organization at the time. And we never stopped during COVID. Our staff suited up in PPE. There was a time where all of the staff were COVID positive, and they were head to toe PPE, as it like the whole suit, like they were in an outbreak movie or something, and we're providing COVID tests. So what they did is kind of the pivot that they made is that they provided COVID testing for our participants, which was valuable because then those participants were eligible for hotel vouchers. And so it kind of became a housing strategy, actually, that people that were COVID positive could stay in a hotel, which during the winter months was pretty clutch for them. And then we continue to provide our syringe services during that time. This was when we were still very young as an agency, and so we were only providing syringes. We weren't providing the full suite of services that we have now. But we continue to try and meet people where they are at. We were doing mobile outreach, mobile testing. We were doing our best to do connection to treatment and care. When the vaccine came out, we invited the health department to provide vaccinations for our participants at our mobile outreach locations and our office locations, and we incentivized those interactions. So if the participants wanted to get a COVID vaccine, obviously we never pushed it on anybody, but if they wanted it, then they also received a Walmart gift card that they were able to use to meet their needs. So it was a truly remarkable time. It was a really scary time, and our staff just really pushed through and, quite frankly, put themselves at risk in order to make sure that our participants were cared for, because nobody was caring for them during that time. Before this webinar started, we were talking about how all these social services shut down, and there was just nothing. There was just nothing for them. And VHRC, to its credit, was one of the few organizations that was able to persevere and never shut down during it.
Thank you for sharing. Sounds like you all were able to pivot amazingly. Thank you. Mike, what did the hotline look like during the pandemic?
I started it in it was late August of 2019, and obviously the lockdowns happened in February of 20 or something like that. So prior to the lockdowns, we really didn't have any calls at all. We had a lot of calls for people asking if it was real, but we didn't have any calls for actual spotting services. But then when the lockdowns happened, all of a sudden our phones started. Sorry, I got my little helper here in the way. When the lockdowns happened, the phones started ringing. And first it was just a couple calls a week, then a few calls a week, then a couple calls a day. Now we're up to 50,000 calls or something. We get about 800 to 1,000 a month or so now. But honestly, I don't know if NUA would have survived had it not been for the lockdowns. Because for that 4 or 5 months, we kicked around the idea of shutting it down. We didn't think it would work when I started it to begin with. I didn't think anybody would trust us enough to call. Being a person with lived experience in that, I don't know if I would have. It's scary. But we kicked around the idea of shutting it down, and then the lockdowns happened, and that first person called and thought, well, maybe we've got something here. So we just kept going. And during that time, I was also helping to open a new syringe exchange program in Midland, Michigan. So we were deemed essential workers, or whatever the term was then. And we still provided services there as well. But yeah, it was an interesting time, and I honestly don't know if NUA would have survived had it not been for that lockdown. Who knows? We may have gone ahead and decided to shut it down, and glad we didn't.
Yeah, it seems like you all definitely filled a space that was needed. I remember during the lockdown how everybody was just looking for ways to connect to others and, support each other and looking for their own support. So I'm sure you all were able to fill that need for some people.
Yeah.
Thank you. Isabel or Bettina, did you have anything to add?
Yeah, I mean, I think our organization changed completely during because of COVID, and became this big outreach program instead of being like a central place, even though we do both. And but I think it allowed us to get to know the neighborhoods better and get out there and you know and really actually meet people where they're at and get the resources to do that, because we didn't really have a choice. So we have a van now that we got during COVID, and everyone recognizes it. So if they see the van go by, they flag us down or yell Spark, and they'll come up and get services from us. So that came out of it. I mean, obviously, I would wish it hadn't happened at all, but it changed our program completely, and we had to figure out how to, work around it. I think also it showed us getting out into doing more outreach really showed us how much community care exists in with our participants, how much they're taking care of each other all the time. And, talking to them allows us to figure out ways to support how that's already happening, because people are out there taking, especially in a lot of the neighborhoods that we go to, they're very isolated from the rest of Baltimore. So, people take care of themselves and each other. And if we can support that, that's great. And I think being out there showed us that. So.
Yeah. Bettina, did you have
Sorry, Jamie. So in the midst of the shutdown of the pandemic was actually when I was getting clean after a relapse of being clean from 20 years from methamphetamines. So I didn't see that side of it, but I do know with Sue Purchase, the CEO founder of our organization, she seen a major increase with what she was doing because nothing was available. And so that's where the idea, and then she had, thought about it before, but that's where the solid idea of we're going to do a mobile unit, because we live in northern Minnesota. And if any of you have not ever been to Minnesota or have never seen photos, it's deep woods. And, we have participants whom could be 200 miles or 100 miles from like the big cities and are in the middle of nowhere and have no services. So our mobile unit now, because of the pandemic and where it's, evolved from, we get to go offer the services. So if somebody calls and they're 120 miles away and no transportation, we will say, if our staffing allows, look at the address, find out where it's at.
Thank you for sharing that. Um, all right. And so our next question, um, I will actually pose this to all of you again. Um, thinking about stigma and discrimination against people who use substances cause so much harm, including increasing the risk of fatal overdose and gender-based violence. What are some of the ways that you counter stigma in your work? And is there anybody that would like to answer first?
I'll go.
Okay.
At Never Use Alone, we all of our operators, before they ever take a call, they're all trained on what information to ask for, when to call for help, and how. But also part of that training is person first language. Um, I don't get a whole bent out of shape too much if somebody uses the word addict, but a lot of people don't like that. I don't refer to myself as that. But when it comes to the J word, I refuse to have that used on the line. But we're sure to train all our operators on definitely things not to say and the importance of why that is. You know, we're trying to change the way society views people who use drugs, and that all starts with conversations, and the words we use in those conversations are very, very, very important. I don't think people realize how important that is. So yeah, all of our operators are trained on person first language. So we try to get it that way.
Yes, as we say here at the center, language matters. Language can hurt and language can heal. So thank you.
I'll jump in. So it's just every day. Like existing is addressing stigma. For example, this morning my office manager for our West Piedmont office was calling saying that the landlord was saying we had to leave because we are in a strip mall there and two people on either side of us are complaining about our participants and demanding that we leave even though we're under a 3-year lease. Stuff like that just is like normal, part and parcel every day. But I think in the context of intimate partner violence and addressing that, we do a lot of work in educating shelters and violence prevention providers in the area. So, for example, none of the shelters in our region and like within our immediate area that we could refer somebody to accepts people who are currently using drugs, which is where our domestic violence program comes from. It was conceived of by one of our case managers who was tired of having our participants, especially our female presenting participants, coming in with, battered faces and bodies. And so she conceived of this idea to get funding for hotel stays, because one of the things that is preventing people with substance use disorder from leaving their risky situation, their dangerous situation, is that they can't go into a shelter. They know they can't go into a shelter. And so what we'll do is we will do emergency housing in a hotel for up to 2 weeks. And in that 2-week time, our case managers are either helping them get on Suboxone or methadone so that they can enter the shelter system, or finding another solution. Can they move in with a family member? Can they get out of state, out of the area? Just problem solving with them, helping them identify goals to keep them safer. We also work with the shelters. Like we had a shelter try to kick out one of our participants because she was on Suboxone. And so that was some education that we had to do, that this is a legitimate medication and you provide medication for all of your shelter guests and you allow them to manage their own medication, and this is no different. So in the intimate partner violence space, we have to do a lot of work to advocate for our participants, and it's challenging. And at the state level service providers and advocates that work on this are aware of it, and it's something that's just kind of it's a slog. It takes a long time to get service providers and shelters to understand the humanity of our participants, and that this is their service population too, and that they have a duty to provide care to them as well.
Yeah. Thank you. Would anybody else like to add before we move on?
Yeah, I can jump in. I think there's 2 ways that go hand in hand that we do this every day. One is like just creating a caring and like drug neutral environment. So, drugs are just something that we all use every day. And we're not gonna put any value on it unless you do, and we're gonna listen to you and talk about it the way you want to talk about it. And also just gaining rapport and making people feel comfortable in general. And then also not ignoring the stigma, not pretending like just because where we work, we're not gonna, speak to you in this way. We're not gonna, treat you a certain way because you use drugs. Not ignoring that exists in other spaces. So we know that a lot of the participants that we work with have had terrible experiences, traumatizing experiences in the hospital and other places that they go to get their needs met. So sometimes it's safety planning around going to the hospital or going to see other providers. It's talking about, you know, experiences that they've had with other people and or talking to other providers and you know, trying to educate what all those different ways. Yeah. So not ignoring that that exists and talking to people about how it makes them feel
Yeah.
and preparing. I'm not saying like, listen, because so many people that we work with are like, we need you to go to the emergency room because your wounds are horrible or whatever it is. And they don't want to go because they've had these terrible experiences. So
Yeah.
figuring out, you know, taking the time that they need to talk through the safety planning for that to happen or yeah, is a lot of what we do sometimes. So
Yeah, that's a great point. Thanks for adding that. And Bettina?
I just wanted to touch on um, the first language. Like for me, when I was hired in this position, um, you know, one of the things that was presented in my interview was, you know, would you be comfortable serving Indigenous and underserved populations? And I was like, pick me. You know, I'm from our tribe that's right here next to Lake Superior. You know, I was born and raised and grew up there. And so it was my passion to want to be able to break that stigma, not just for, you know, not just for the person that is in active addiction, but for those around that, you know, everybody that's interconnected with that. And so, you know, the first language, like we'll have participants come in and for some reason, a lot of people, I don't know why, but when they come through the door, they automatically think I'm Puerto Rican for some reason. And it's kind of a joke here with us and our staff, you know, they're like, oh, did they think you were, you know, native today? Or did they think that you were Puerto Rican? And because they'll hear that conversation and joking around. Um, and so when someone comes in the door, even though I'm a newborn to my language, because if you don't use it every day, you lose it. And so our language is such a dying language, our Ojibwe, you know, our Ojibwe language. And so when I can use it for myself to use it, it feels good when the participants hear it, but then they hear it and they're like, she knows the language. And I build those partnerships and relationships with those participants. And I have some that come through that are like, I prayed you were going to be working today because I just wanted to hear, you know, boujou, minogigije, like it's those little phrases, or like our native humor, you know, we have some crazy humor and I use that humor in certain situations with participants. And I'll use an example. Yesterday, I had an elder who had not had insulin in over a week. He's homeless. He's lost everyone and everything he had. And we thankfully work directly across the street from our Center for American Indian Resources, our medical building. And I said, are you an enrolled band member from a tribe? And he said, yes. And I said, we're going to get you help. I took him over. I brought, you know, another staff member of ours actually stayed with him here across the street and got him all of that services. And it's that, you know, like being able to not only for the participant breaking that stigma that, you know, in my experience, like we carry that as a person that, you know, is actively using, we carry that, we know that stigma and experience it every day. So being able to have them understand like we're not doing that. There's no judgment whatsoever. You know, I mean, I'll give hugs to people that haven't showered in weeks upon weeks. And it's because everybody needs to be loved no matter where they are from. So yeah, I really love that first language that you touched on because it's a major factor in what I do in the building and the demographic of people I serve here. So
Thank you. Thank you all for just caring about the people that you work with and meeting them where they're at and seeing them as people, um, and not as the substance that they may be using. So thank you. And I have another question, and I'll direct it first to Bettina and Danny, but again, I'll open it up to all of you at the end to respond. But I know that both Bettina and Danny have mentioned um, some of the work that you've done with people also experiencing gender-based violence. What are some of the ways that you've engaged with people who've experienced gender-based violence and worked together to support their self-defined safety and well-being? And we can start with Danny for this one, please.
Sure, yeah, this is really two ways that I think our organization focuses on this. First, if any of you, I'm sure most of you guys are familiar with the phrase trauma dumping, but often we are the holder of a lot of that trauma. One of the things that's really common for people of a femme or female experience that are unhoused, that if their boyfriend or their trafficker, often those lines are indistinguishable, is locked up, gets picked up, and is in jail for that night, that person is incredibly unsafe. And they do, because they are on the street alone, they do experience rape, they do experience some pretty extreme gender-based violence. And so understanding that dynamic and holding space for that dynamic, right? That I know this person that you are very concerned about being locked up and are genuinely scared about having that person locked up. You know that person also harms you and does physical violence to you on the regular basis. And I also know that now that they're locked up, your experience of violence is greater. And that's like really complex tension to hold. And so it's holding that tension, like expressing that compassion and sadness of what happened to them last night after their partner got picked up. So that's just, all of our staff members are kind of trained in that understanding of like, this is complicated. And we also, the person that is harming them is also a participant in our program, is also getting supplies from that. And so holding that tension, right? That this guy is violent, but we, when we're unhoused and we're dealing with undiagnosed and untreated mental health issues, and when we're using substances, we talk about happy drunks and mean drunks, right? It's like that you also have to hold the humanity of their abuser. And so it's really complex and complicated. And so we create space within our staffing to like discuss those complexities, to express our feelings of anger or sadness around that. And then for our case managers who are engaging more deeply with these participants that are victims or survivors of violence, it's working with them to not push them to leave their situation, right? It's working with them to, how can we make yourself safer? Can I teach you how to prepare your own shot so that you're not relying on your partner, because maybe your partner prepares really strong shots that limits your ability to think clearly, to advocate for yourself, to manage your own body, right? So are we teaching them how to prepare their own shots so that they have more control over their body? Planning out of where, we've taken in so many animals, dogs and cats, that were a part of the situation, and they were trying to get into treatment or they were trying to get away from their abuser. And so we take in the animals so that they could do that, so it's really working with, and everybody's trained to do this. This is best practice in the gender-based violence space, that their safety plans are self-defined. But when you're working with people who are unstably housed, who are using drugs, that gets real detailed and real complicated, and being comfortable with that and truly letting that person, your participant that you're supporting, define their boundaries, their goals, their strategies is just so important.
Yes, thank you. Bettina, did you have anything to add?
Yes, I do. I'll keep it short and sweet. So, I think about the gender-based violence, being somebody of lived experience in a marriage of 6 years, it was violent. And I take that, that hurt that I felt at the time, I take that now. I've learned to process it so differently, but I take that now and I use that as energy to help someone else to try to get out of a situation. But the gender-based violence, I didn't look at it as, as a very young, I was in my early 20s, late teens when I first was married. I didn't look at it as, female and female, or male and male, or vice versa, or I always looked at it as a man and a woman. And growing up, and then now getting clean and working in the place that I work, in the organization that I work, so many things have been happening with learning. I always say I'm a newborn. I'm a newborn to harm reduction. If you would have asked me 5 years about harm reduction, I would have said, what are you doing and why are you giving these things to these people? Wow. And today here I am in the position I'm in. But I think, being able to go out in the encampments, holding space for people that, we have people that don't feel comfortable with certain participants or genders in the office. We will make that space for them. So at that time, when we have that time with them, for when they're there for services or just to come in and talk or whatever it might be, we give that to them so that they trust us enough that we can sit down and come up with a plan. And, I've sat down with participants and said, what do you think will work for you? What hasn't worked for you? And then we try to build that structure of, well, what hasn't worked, what's going to work, what can we do? We also have it so that we do that outreach, and we go and we can check on participants, or, hey, hey, I seen you were walking with so-and-so earlier. Did you happen to know where she might have gone? Is she doing good? We just wanted to see if she needed supplies. And then, we do that stuff. So it's just, I like how you had mentioned earlier before me, the keeping the space and holding space for them, because it's so important. And people say, meet them where they're at is such that cliche of that phrase, but meeting them where they're at for where they need to be, and what they think is going to best work, and just helping guide them through that. And not saying, well, I think you should do this, and I think this is going to work. What do you think? And, give it back to that participant. What do you think? And how would you like me to help you with that? I think makes all the difference in the world. And just that loving compassion with someone, being able to help them break those barriers and get those walls down so that they can get the help that they need.
Thank you. And so, as we come to a close, I do have one more question I'd like to ask all of you. And that question is, what's something you want everyone tuning in today to think about or do differently to better support survivors who use substances? And we can start with Mike.
All right. I think couple of the biggest things that need to change is the old idea behind tough love needs to be destroyed. There is, boundaries are fine, but tough love, turning your back on your kid, kicking them out, and not answering the phone until they're ready for a ride to treatment or whatever they're told. There's no evidence supporting that ever works, or if it's helpful in any way. And any experience I've had with it was a negative experience, and it doesn't usually end well. So getting rid of tough love, I think, is a big thing. Obviously, supporting and understanding harm reduction, supporting multiple pathways. I did the 12-step thing for in and out of the room for over a decade, and it never really worked for me. And that's, I'm among the 95% of people it doesn't work for. And it doesn't mean that the program doesn't work, it just doesn't work for a lot of people. So whether the person wants to go to an NA meeting, or they want to get on Suboxone or methadone, or they're using kratom and cannabis, or microdosing with mushrooms, whatever they think will help them, along their pathway. Accepting multiple pathways and promoting any positive change. If we stopped and celebrated more of the small victories, we'd go to a lot less funerals.
Mm. Yes. Thank you. Isabel, would you like to?
Yeah, I think I always like to share this, but I think one of the best things I've heard from my colleagues that I've learned about harm reduction is and working with people who use drugs is not to celebrate until the participant has celebrated. So if someone, if someone tells you, listen, hey, like I stopped using whatever, like you're not gonna just be like, oh my God, that's so amazing. You're gonna listen to them and see how they're expressing and reflect their feelings back. Because if you like place that good on sobriety, then it's going to cause all types of different things that are going to be messed up. And you want to listen to what they're saying to you and why they're saying it. They might be saying it because they lost their kids and they have to, they have to stop using the drug that they want to use. You have to listen to what they're saying. And then the other thing is everybody should learn about overdose prevention sites. We didn't really get to talk about them today, but everybody should go out and learn about overdose prevention sites, watch some documentaries, maybe look up what they are. They're really awesome. They can save lives and we need them everywhere. So
Yes. Thank you. Danny?
I would say methadone is medicine, Suboxone is medicine, Subutex is medicine. It's all medicine. Heroin is medicine. Fentanyl is medicine. Methamphetamine is medicine. And people are using these drugs for very legitimate reasons. And when you're talking about supporting somebody in a crisis situation, everybody on this call, I'm assuming, really knows what it takes to leave a dangerous situation. What a overwhelming task that is. Destabilizing their chemistry at the same time, to me, doesn't make sense. And so one takeaway that I would ask is recognizing that when you are supporting somebody who is a survivor, remembering all the stuff that they've done and are doing, all the changes that they're making, and don't ask more of them, right? If they use an opioid and you can support them getting on methadone, which is a safe supply, if that's what they want, do it. If they are on methamphetamines and you can support them on getting on Adderall, which is a safe supply because it's the same drug, do it. If you have the latitude to let them continue using those substances while in your care, do that. And from a CPS standpoint, many parents use drugs and are great parents while they are using those drugs. And remembering that as well, that you do not have to remove a kid from a home just because a parent uses marijuana or meth or whatever. You need to look at the actual environment and the capacity of that parent to provide care, not what substances happen to be in their system. And thank you so much for being here and caring. You're already taking the first step by coming to this webinar, and I really appreciate it.
Thank you. And Vatina?
I guess I just want to end with, I've had such an outpouring of love in the last 4.5 years. Almost 4.5 years. April 8th was when I started methamphetamines in 2020. And I've learned so much. And I used to take so much for granted. And it's the little things like just remember that we don't know what took place before you had that interaction with that person. Whether it's a staff member, whether it's somebody you're trying to educate, they have the stigma against a person in active use. Or someone that is experiencing domestic violence. There's someone child, there's someone's loved one, and I always look at it, I too did the NA structure for myself when I first got clean, but I look at it like I turn all of the negative that I had carried for so many years. And if I can wake up and I have a heartbeat in my chest, it's going to be a good day no matter what. And if all the difference I made in somebody's day was holding the door for them, and that was the biggest thing they had happened to them, mission accomplished. Thanks for letting me be part of it today. And thank you for all that you guys do too. I appreciate each and every one of you.
Thank you all so much. This has been an amazing session. Thanks to our interpreters and the NCDVTMH team. Thank you to everybody that joined us today. It's been an honor working with all of our panelists. You all are amazing, amazing people that are doing amazing work. I'll also want to invite those of you who are joining us to click on the survey link provided in the chat and let us know what worked and how we did today. And within the next week or so, we'll send you all a follow-up email with a link to the recording for today's webinar, in addition to any slides or materials that we may have mentioned. And all of these things will also be available on our website. You will also receive certificates of attendance for your time today and a link to the evaluation for the webinar. Thanks again. Thank you to our amazing panelists, and we hope you have a wonderful afternoon.
Thanks, everyone. Thank you, Jami, for pulling this together, and all the staff. Really love it. Thanks.
My pleasure. Thank you all
Yes,
so
thank you
much.
so much. I hope to be able to still stay connected and touch base with everybody from here on out. It would be fantastic. Thank you. Have a wonderful afternoon.
You
Bye-bye,
all
everybody.
too.
Thanks for having me.
Of course. Thank you. Bye bye.